Now you are live now, and I will start recording.
ఏమైందండి?
So, YouTube లో start చేశాను. You can start now.
Hello everyone, myself, I'm Dr. Nawal. I'm back again with a live class of ENT. So today we'll have a topic called cholesteatoma and chronic otitis media. Important and a very long topic of ENT, yet very, very important in your academics, in your clinicals, and rest of your practice. Before that, I'll give you a small introduction to our platform. So our platform, Auricle, helps you prepare for university exams and for next exams. We have rapid revision for all important questions. We have quick revision platforms. We have high yield topics where we teach all the students before they go for an exam. And most expected topics will be covered on this platform. Okay. So today we have a long essay, a short essay, and a very short essay. It's there on your screens. If you have pen and paper, everyone, please make a note. So what is cholesteatoma? Etiology, clinical features, management, and also describe acute otitis media and chronic otitis media with signs and symptoms management. Short essays, we have a list here. And very short essays also we have a list here. Now here there are a few topics that we have already covered. So we'll more focus on the longer essays, what is cholesteatoma and acute otitis media and chronic otitis media. Now, why do you have to choose Auricle? Because we have recorded classes, live classes, we have practical sessions, we have exam modules for the students, and we have hard copy book sets also. What about recorded classes? You can come back again, follow up with those videos. You will have it on your applications. We use 10 years of question papers to make classes for these students, and people who are preparing for FMG or next exam can also benefit from these recorded classes along with academics. Coming to live classes, we prepare effectively for your proficiency exams with 45-day live class series we have, where we take questions again from the last 10 years question papers, and most repeated questions will be put in front of you. The educator will help you understand the topic. And if you have any questions or queries, you can join in and ask us any question that you have in your mind related to that topic. We have an express exam module where we complete syllabus in 20 hours. Now, this is only for revision. This is only for revision, not like you did not attend the classes and then you jump to this express exam module. It's not going to benefit you in any sort of form. So we have a complete syllabus. We complete syllabus in 20 hours. This is just a swift revision before your exam. We teach you how to write answers, how to present your answers in your university exams. And it's all done by expert educators. So again, we have one-to-one doubt clearing sessions. This is useful for students who are very curious to know about certain topics and who have doubts and who cannot reach their academic professors in their universities or colleges. So it is our most student-centric approach, and we have a personalized attention given to every student, and it is a safe learning environment where everyone can benefit from. Coming to the point of hard copy notes are in-depth coverage topics. We covered the topics from previous year's question papers. These are made by very good and experienced educators who will teach you in this book how to write the answer, what are the concepts, and what is the study plan, and much more. So you don't have to get into buying a textbook before your exam. You can just use these hard copy notes if you want. And it is an interactive learning session where you can participate in a live doubt clearings and MCQ calls or Viva was questions and many more. Coming to the part of question bank, we have an application. We have a 3 levels of difficulty levels in this application. Beginner to an expert level. You can customize the question bank according to your comfort and according to how much you're ready and how much you know about the topic. And this helps you to prepare for NEET, NEET PG and FMG as well, and also for your academics. Best part is that we treat students for practical sessions before practical exams. You will have educators online who will help you uh, present yourself in a practical exam, how to answer the question, what can an external ask, and what you have to say, how you do the things around in the practical exam and all. Now, for a discount or subscription, you can use the code DRNAWALMOHAMME20 for discount for the plans. And we have 4 plans here. The first 2 plans, you don't have enough benefits. Just last 2 benefits we won't have. But then a complete learning plan or an ultimate MBBS plan, you will have all the benefits. The QR code is mentioned here before we jump or dive into our topic. And let's start with our topic. Before we start a topic, I want to just launch polls and quizzes for the students before we start, if I can. Okay, I think we'll do it in the end. Okay, so today we have a topic called cholesteatoma and chronic otitis media. So what happens in cholesteatoma? What is actually cholesteatoma? So I'll just present a case scenario in front of you. What will actually happen to the patients with cholesteatoma and how will they present in the exam hall? When you have them in an OP, how do you deal with them? So let's assume that there's a patient, there's a boy who's brought to a clinic and he has a persistent ear discharge. All right. You have given him an oral antibiotics prior to this. This is a recurrent condition of recurrent otitis media, where he's having otitis media every month, let's say. Now, there is retraction. When you do an otoscopy, you see that there is a retraction of superior portion of tympanic membrane, and there is a pearly white mass in his external auditory canal. Now, remember, I'm telling this word called pearly white mass in an external auditory canal. Okay? So, this is a condition of cholesteatoma. A patient will present to you. He will come to the clinic with persistent ear discharge, maybe right, maybe left. Okay, he's already on oral antibiotics because he had a condition of otitis media before. Okay, and it is a recurrent condition. And when you do an otoscopy, you see that there is a retraction of superior portion of tympanic membrane, and there is also a pearly white mass in his ear. So this is a typical case, this is a typical presentation of cholesteatoma. So what is actually cholesteatoma? So the definition is actually that normally what happens is the middle ear cleft, it is lined by different types of epithelium. Okay. It can be ciliated columnar epithelium in the anterior part and inferior part. It is cuboidal in the middle part, and it is pavement-like in active. So let's assume that middle ear cleft I'm talking about. So if you remember that we had a class of anatomy of the middle ear. So we drew middle ear somewhat like a box there, right? So we have an anterior portion, inferior, and we have a pavement like attic part, right? So anterior and the inferior part has ciliated columnar epithelium. So let's assume, I'm going to highlight. So this is your anterior part. So let's assume an anterior part. Anterior and inferior part, ciliated columnar epithelium. All right. Now coming to the attic part, it is pavement-like. It will be like a pavement. And we have a cuboidal part that comes in the middle. Okay. So anterior, middle, and attic. Anterior and inferior. So anterior is ciliated columnar epithelium. Middle part is cuboidal and attic is sphenoid. This is normal. Okay. Now the middle ear is nowhere lined by keratinizing squamous epithelium. Okay. Keratinizing squamous epithelium is nowhere lined in the middle ear. Now it is the presence of keratinizing squamous epithelium in the middle ear or the mastoid that leads to cholesteatoma. So we can see that it is a skin in the wrong place. So nowhere in the middle ear we have a keratinizing squamous epithelium. But if you see keratinizing squamous epithelium in the middle ear or in the mastoid, it means that it is cholesteatoma. So the term cholesteatoma is actually a misnomer. You will think it's something related to cholesterol in the ear. No, it's not like that. It is because neither it contains cholesterol nor it contains tumor. Okay, it is a condition where the skin is replaced by other type of skin. So keratinizing squamous epithelium is a major thing that plays an important role in cholesteatoma. Now, essentially what happens is that cholesteatoma consists of two parts. Okay, here if you can see, change the color of my pen. So cholesteatoma has two parts. It has matrix and it has a central white mass that contains keratin debris. So it is like a circle. Let's assume it's like a circle. Okay, so this is central white mass and this contains keratin debris. And it has a matrix. Okay, now this matrix is made up of keratinizing squamous epithelium. This matrix is made up of keratinizing squamous epithelium. And the central white mass that contains debris. This debris are actually produced by the matrix itself. So for this reason, it has been named as, it can be named as epidermosis or keratoma. So, okay, epidermosis or keratoma. The examiner might ask you this question to confuse you. So, coming to etiology of cholesteatoma. So what happens is that the patient here will have genesis of cholesteatoma is actually very controversial thing. In any theory, it explains how squamous epithelium is appeared in the middle ear cleft. Okay, so there is presence of congenital cell rest. Okay, it might be invagination of tympanic membrane. It can invaginate the tympanic membrane. This is known as Whitman theory. So what actually happens in Whitman theory is that they say that the tympanic membrane is invaginated from attic or posterior superior part of pars tensa. In the form of what? In the form of retraction pocket. So retraction pocket, if it is there, so what actually happens is that let's assume this is your this is your ear and this is osteition tube, middle ear, tympanic membrane. Tympanic membrane, we have pars tensa here, right? And this is your ossicular bones. Now, if you have cholesteatoma, here you might develop a retraction pocket. Okay, so invagination of tympanic membrane from attic or posterior superior part of pars tensa in form of retraction pocket, it is known as Whitman theory. Okay, now we have said that there are different etiopathologies that you can believe. One is presence of congenital cell rests, right? The other one is invagination of tympanic membrane either from attic or from posterior superior part of the pars tensa in the form of retraction pockets. The other one is basal cell hyperplasia. So basal cell hyperplasia is known as Rudy theory. What happens here is that according to this theory, the basal cells of germal layer of skin, they will slowly proliferate along with infection and they will lay down keratinizing squamous epithelium. All these are theories. We don't know the exact condition or exact origin of cholesteatoma. The only thing we can think is about theories. So one is Whitmark theory, the other one is reduced theory, where they say that basal cell hyperplasia is there, and along with infections, they might lay down keratinizing squamous epithelium. The other one is epithelial invasion. This is known as Haberman's theory. Here, what they say is that the epithelium from the meatus or the outer part of the tympanic membrane, it grows into the middle ear, and that the perforation is already there. That is a pre-existing perforation. They will go through that pre-existing perforation, and they will form a marginal type of annulus tympanicus that has been already destroyed. Okay, so epithelial invasion is known as Haberman's theory. Here they want to tell you is that according to this theory, the epithelium from the meatus or the outer part of the tympanic membrane grows into the middle ear through the pre-existing perforation. If there is a perforation already there, right? So it grows through that perforation, and it forms and enters into the part of annulus tympanicus which is already destroyed. Now the other part is Said's theory, metaplasia, right? According to Said's theory, what they say is middle ear mucosa, just like how we have respiratory mucosa, middle ear mucosa undergoes metaplasia due to repeated infections, and it transforms into squamous epithelium. Anyways, this makes sense. A lot of time, metaplasia, Said's theory is more commonly uh, involved in origin of cholesteatoma. Okay, so this is what they say is malignancy due to recurrent infection. In short, okay, so these are the origins of cholesteatoma. Said's theory we have, Haberman's theory, reduced theory, and Whitmark's theory. Four theories, and one is presence of congenital cell rest. Now, mostly what happens is this presence of congenital cell rest is very rare, very, very rare. Cholesteatoma is usually acquired than it is congenital condition. Okay. Now, this is how it looks like. We have an inner mass. You can see keratin mass. And we have an outer layer, fibrous stroma. And between the keratin mass and fibrous stroma, we have stratified squamous epithelium. Okay. Here you can see retraction pocket, how retraction pocket happens here. So slowly, there's a pocket formation here, right? And if there is a basal cell hyperplasia means the basal cells of the skin proliferate with the influence of infection, and they will lay down the keratinized squamous epithelium. This is basal cell theory here that they have applied. The other one is epithelial invasion through posterior superior perforation. Okay, this is Whitmark's theory. All right, so retraction pocket is here. Now, classification of cholesteatoma. Before that, here, classification of cholesteatoma, we have congenital, acquired, and primary. So congenital, acquired, primary, and acquired secondary. Sorry, we have congenital, we have acquired primary, and we have acquired secondary. So what actually happens in congenital condition? What I just said now is congenital is a very rare part that plays in cholesteatoma. It arises from the embryonic epidermal cell rest. Okay. Embryonic epidermal cell rest. And congenital cholesteatomas occurs at three important sites. It either occurs in the middle ear, or it either occurs in the petrous apex, or it either occurs in the cerebropontine angle. I'll write it down. Middle ear, petrous apex or cerebellopontine angle. Okay. And this will produce all the symptoms that are located according to the site. Like if it is a cerebellopontine angle, it affects two nerves, facial nerve and vestibulocochlear nerve. So that will be damaged. If it is a petrous apex, it will affect simultaneously. If it is a middle ear, it will show symptoms of middle ear infection. So middle ear congenital cholesteatoma can be present as a white mass. Remember, I told you in the beginning, a case, a boy comes to the clinic with white mass. So middle ear congenital cholesteatomas will present as a white mass behind an intact tympanic membrane. So right, yet the tympanic membrane is intact. And there will be white mass behind the tympanic membrane. And always remember, cholesteatoma will only cause conductive hearing loss. Okay, it can be sometimes discovered on routine examination of children. It can be sometimes asymptomatic, but usually it will show symptoms of conductive hearing deafness. Now, it will spontaneously rupture in some cases through the tympanic membrane, and that discharge will be seen in the external auditory canal. Okay, now this is all about congenital condition. Coming to the part of acquired primary and acquired secondary. Now you can see here there are 2 points which says acquired. Okay. So acquired is because it is usually acquired condition, very rarely a congenital condition. So in primary acquired cholesteatoma, I'll go to this diagram so that you understand it very clearly. So we have an oscillation tube obstruction. Let's assume that a patient is having an oscillation tube obstruction. The next thing that you can see is that there is a building of negative pressure in the middle ear. You can see our previous videos where we have explained how the negative pressure is created in the middle ear. Okay, so there will be persistent negative pressure in the middle ear because your oscillation tube is blocked. So it is pressurizing the middle ear through the tympanic membrane. Now what happens is that there will be a formation of retraction pocket. Attic or posterior superior retraction pocket will, here you can see in the diagram, like what we had before, slowly it will slide in because there is a negative pressure building up here. Right? So there will be a formation of retraction pocket. Now, what happens when there is a formation of retraction pocket? We land into a condition of primary acquired cholesteatoma. Now, when you have primary acquired cholesteatoma, there are 2 things that you have to think of. It can be due to proliferation of basal layer, or it can be due to metaplasia of middle ear mucosa. Now, there are 2 important conditions, like I told you, 2 important theories. Here we have, first theory is metaplasia, that's Sage's theory, and the other one is basal cell hyperplasia, that is Rudy's theory. Right. So, what happens is there will be metaplasia of middle ear mucosa, or they can be because of proliferation of basal cell layer. You can see here, any 2 can be the reason. Now, once you rule out this, you can treat accordingly. Now, if the patient comes to you with repeated infection because through perforation, let's say he had an acute otitis media that has developed into recurrent otitis media, right? So this is called as repeated infection through perforation. You can assume it can be metaplasia of middle ear mucosa. Okay, now if it is because, now if the metaplasia is because of repeated infection through perforation, that becomes a secondary acquired cholesteatoma. Here, okay, or if it is an acute necrotizing otitis media, we have already covered this topic in the previous class. So if it is a condition of acute necrotizing otitis media, there will be a large either central or a peripheral perforation of the tympanic membrane. Now, what will happen? The epithelium will migrate through that perforation and enter into the middle ear. Now, this again will cause a secondary acquired cholesteatoma. So in exam, this table is very important. If you by heart this table and then you write it in a paragraph form, you will 100% get marks. So remember, oscillation tube gets blocked. There is negative pressure building up in the middle ear. Now, what will happen? There will be formation of retraction pocket and it will lead to primary acquired cholesteatoma. Now, primary acquired cholesteatoma, it can lead to secondary acquired cholesteatoma. two conditions we have to make sure: metaplasia of the middle ear or proliferation of the basal cell layer. Two theories. Now, if there is repeated infection through perforation, it can be metaplasia of the middle ear. It can be secondary acquired cholesteatoma. Now, if it is acute necrotizing otitis media, there will be a large central or a marginal perforation of the tympanic membrane that will cause epithelial migration through perforation and lead to secondary acquired cholesteatoma. These are the classifications of cholesteatoma. Now, how does cholesteatoma expand and how will it destroy a bone? So one is the cholesteatoma enters into the middle ear cleft. It invades the surrounding structures also. It's like a cancer. First, it will follow the path of least resistance, the wider part, and then by the enzymatic bone destruction. So first what happened, it will follow the path of least resistance. The bone is already destroyed there. The enzymes have released. Now it will follow the enzymatic bone destruction path. Now, in active cholesteatoma, it can move backwards into the adductus, antrum, and mastoid. So these are middle ear cleft, right? So adductus, if it is an active cholesteatoma, it will extend back into the adductus, antrum, and mastoid. Downwards, it will enter into the mesotympanic. This is backwards, then it is downwards. All right. Now, what will happen if it enters medially? When it enters medially, it will surround the incus and malleus. So you have to imagine it's like a middle ear, right? It is entering backwards into the adductus, antrum, mastoid. That's the middle ear cleft, right? It is entering downwards into the mesotympanum, and then it is entering medially. So it first goes back, then down, and then medially. Medially, it will involve the incus and head of malleus. Now, cholesteatoma has a property to destroy bone. That is the biggest property that cholesteatoma has. Cholesteatoma has a property to destroy bone. It causes destruction of ear ossicles. It will destroy the labyrinth. It will destroy the canal of facial nerve. It will destroy the sinus plate, tegment tympani. It will destroy anything that comes over its way. Okay. It is attributed to various enzymes. Also, it has various enzymes. It is attributed to various enzymes. So, bone destruction by cholesteatoma is actually due to various enzymes such as collagenase, acid phosphatase, proteolytic enzymes, and because of liberated osteoclast and monocular inflammatory cells also in cholesteatoma. So, I'll mark it here. This can be a question asked by an external. So, attributed various enzymes for cholesteatoma or collagenase, acid phosphatase, proteolytic enzymes. All these are liberated by osteoclasts and monocular inflammatory cells. Okay, it can destroy ear ossicles, it can destroy labyrinth, it can destroy canal of facial nerve, can lead to facial palsy, it can destroy sinus plate, tegment tympani, and cause complications respectively. So this is how the cholesteatoma is expanded and it will lead to destruction of bone. Now coming to other topic that we have is chronic otitis media. So we now know the definition of cholesteatoma, origin of cholesteatoma, classification of cholesteatoma, right? And we know how the cholesteatoma is expanded and how it destroys a bone. Now, okay, we have a diagram here where you can see this is external auditory canal, right? And we have a tympanic membrane here and we have a retraction pocket. Pockets forms and skin cells get connected here. Retraction pocket. Now you can see a negative pressure here building up because the external auditory canal is blocked. So cholesteatoma will grow. At first, it is likely to grow into and then destroy the structures of middle ear, right? In the time, it may grow and erode around the damaged structures in an inner ear and erode into the bone of nearby skull and brain. So this is how I said it will move back it will move down, and then it will move medially. Okay. Now, what will happen? Eardrum is sucked in due to negative pressure caused by blockade of Eustachian tube. Okay. So if there is a blockade of Eustachian tube, there will be negative pressure building up in the middle ear, and it will lead to a retraction pocket followed by cholesteatoma. This is a very good diagram. Now, coming to the topic of chronic suppurative otitis media. So, chronic suppurative otitis media is a long-standing infection of a part or whole of the middle ear cleft. Okay, it is a chronic otitis media of a long-standing infection or a part of a whole of the middle ear cleft. And it is usually characterized by ear discharge. The patient will come to the clinic with an ear discharge and permanent perforation. Okay, the perforation will become permanent when its edges are covered by squamous epithelium. Now remember this. Okay, I have mentioned here in the perforation becomes permanent when its edges are covered by squamous epithelium. Okay, now permanent perforation can be similar to epithelium lined by fistulous tract. So it can resemble fistula also. So chronic suppurative otitis media main symptoms is an infection of the middle ear cleft leading to ear discharge and permanent perforation of the middle ear. Now, this is an important table of chronic otitis media. So chronic otitis media classified into two: mucosal disease and squamosal disease. Okay. Can be mucosal, can be squamosal disease. Okay. So mucosal disease are itself into three: active, that is chronic suppurative otitis media; inactive, it is only when there is permanent perforation; and healed, this is adhesive otitis media. Three in mucosal: active, inactive, healed. Active is chronic suppurative otitis media, inactive is permanent perforation, and heal is adhesive otitis media. Now, squamous disease, you will have retraction pockets and the cholesteatoma will be active now. Cholesteatoma can follow into chronic otitis media. If a patient is having cholesteatoma, he can have a condition of chronic otitis media as well. And if cholesteatoma is still active, it will lead to chronic otitis media. Or if the patient is having a retraction pocket in pars tensa or pars flaccida, it is known as atelectic ear. So in that condition also, we say it is a chronic otitis media. All right. So it is divided into two and then into 3+2. This is classification of chronic otitis media. So in exam, you will have to write the definition of chronic otitis media. Then you will have to write classification of chronic otitis media. Chronic otitis media will also have perforation of tympanic membrane. So perforation of tympanic membrane, you have to know that attic and posterior superior margin perforation is usually seen in dangerous type of chronic suppurative otitis media. If it is an attic and posterior superior marginal perforation, it is called as dangerous type of chronic suppurative otitis media. I'll mention it here. Danger in chronic suppurative otitis media, it is attic or posterior superior perforation of the marginal perforation of tympanic membrane. And this is usually associated to what? Just now we learned that topic, cholesteatoma. Okay. Now, stratified squamous epithelium from the external auditory canal can grow into the middle ear and it can form any type of marginal perforation. Okay, therefore, all marginal perforations are considered dangerous. Central perforations are considered safe because cholesteatomas are not usually associated with them. But if there is marginal perforation, it is usually called as dangerous. So again, if it is a dangerous condition, it is marginal perforation. So perforation of tympanic membrane, it can be in pars flaccida or it can be in pars tensa. Now, pars tensa, it can be central, it can be marginal. Again, go back to the anatomy class and listen to the anatomy of tympanic membrane so that you know pars tensa, pars flaccida, and what does it mean by central perforation and marginal perforation. So now central perforation can be anterior, posterior, inferior. Just remember it like that. Forget the subtotal part. Remember anterior, posterior, inferior, central. And marginal can be posterior, superior, anterior, inferior. Posterior, superior, anterior, and inferior. Now, anterior means anterior to the handle of malleus. Posterior means posterior to the handle of malleus. Inferior means inferior to the handle of malleus. So here the relation is to the handle of malleus. Now, what does it mean by subtotal when there is a very large perforation of pars tensa, but the parts of pars tensa are still preserved, may or may not be preserved? That is subtotal. Total means there is complete obliteration of the pars tensa. So marginal perforation destroys even the annulus, the sulcus. It will destroy the whole part. Okay, it can be posterior, superior, anterior, inferior, or total. So perforation. So there are two tables that you should remember for chronic suppurative otitis media. And this is a very important repeated question in the exam. Definition, you should write classification of chronic suppurative otitis media and perforation of tympanic membrane. How will it cause perforation of tympanic membrane? Now we have a diagram here. You see here. Central perforation, anterior to the handle of malleus. Central perforation, medium size, central, and we have a subtotal perforation. We have here and there. Now, total perforation, you can see the whole of the pars tensa is gone. Right? Attic perforation, this is seen in pars flaccida. Right? We have posterior superior marginal perforation. Here, you can see posterior superior marginal perforation. This is the most common type. In exam, the more diagrams you draw, the more marks you get. And the less you will have to, work on your written part. Just draw big diagrams and try explaining the examiner boldly and you will get impressed and he'll give you marks. Remember, the more diagrams and the more tables you put because the examiner has to correct a lot of papers, right? So you can just draw diagrams and make his work easy. He'll give you bonus points. Now, this is types of perforation in tympanic membrane. This is chronic suppurative otitis media. Now, coming to the clinical features of chronic suppurative otitis media. So, clinical features, the patient will have ear discharge. Ear discharge can be mucoid or mucopurulent. It can be constant. It can be intermittent. Okay, mucoid, mucopurulent, constant or intermittent. Hearing loss, what type of hearing loss we'll see? Just like what we see in cholesteatoma, it will be a conductive type of hearing loss. And sometimes the patient will tell you that he hears better in the presence of discharge than when the ear is dry, when his ear is dry. So that is actually known as paradoxical effect. He will tell you that when I have discharge in my ear, I hear better. And when my ear is dry, I cannot hear. This is because the round window, it has a shielding effect. So if the round window shielding effect is produced by discharge, that will help to maintain the differential phase in the ear. In the dry ear with perforation, the sound waves will go and strike both oval and round windows. This will lead to the cancellation of sound effect, we can say like that. So I repeat, the patient can have a paradoxical effect. That is that he will tell you that he hears better in the presence of discharge than in the dry ear. This is because the round window shielding effect that is produced by the discharge. So discharge actually produces a round window shielding effect. If it becomes dry, what will happen? The sound waves will go and strike both the windows, oval window and round window, and it will cancel. They will cancel each other. And this will lead to some defect in the hearing loss. This is actually the physiology of hearing uh, in the chapter hearing loss. So, anyways, in long-standing cases, what will happen? They will also have cochlear damage. Okay. So when there is cochlear damage, it will become mixed type of hearing loss, sensory neural hearing loss and conductive hearing loss. But usually it is a conductive hearing loss. But if the cochlea is damaged, it becomes mixed type of hearing loss. Okay. Third point is perforation. So first clinical feature is ear discharge. It can be mucoid, it can be mucopurulent, it can be constant, it can be intermittent. Okay. Hearing loss, we all know that it is a conductive type of hearing loss, but if the patient's cochlea gets damaged in a long-standing cases where they don't approach for treatment, they will have sensory neural and conductive type of hearing loss. Coming to the point of perforation, it is always central. It can lie anterior, posterior, or inferior, but it is usually central. It can be small, it can be medium, it can be large, just like how we saw in the diagram. Okay. So perforation is there. Usually it is central. Now size, it varies. Now, middle ear mucosa, it is seen when the perforation is large. You can only see middle ear mucosa when the perforation is very large. Usually, you will see it as pink and moist, and it will look inflamed, it will look red, it will look swollen or edematous. And sometimes some patients might even show polyps in middle ear mucosa. Okay, so there are these are the clinical features of chronic suppurative otitis media. Now, how do you treat a patient with before treatment? I have not mentioned this in the slide, but because it was least of important, but I just want you all to know that how will you even diagnose the patient? How will you do an assessment on the patient of chronic suppurative otitis media? It's first that you can do an examination under microscope. Okay, so what you do, it is a condition, it is a procedure where you see an ingrowth of squamous epithelium from the edges of proliferation, or you can see status of ossicular chains, you can see tympanosclerosis, you can see adhesions. Okay, this is how you diagnose it under the microscope. The other way is doing an audiogram. So if you do an audiogram, you will analyze what degree of hearing loss and what type of hearing loss this patient is having. Usually the hearing loss is conductive deafness, but it can be a sensory neural element if the patient is having cochlear damage, right? Now, coming to culture and sensitivity, you can do culture and sensitivity of an ear discharge before you start giving them any antibiotic. If they have any ear discharge, you can do a culture sensitivity of ear discharge. You can do X-rays and CT scans of temporal bone. Now, mastoid is usually sclerotic, but it can become like a clouding of air cells like structure if there is a evidence of bone destruction. Okay, so if you feel like there is an involvement of bone in this condition, you can do mastoid X-rays or you can do a CT scan of temporal bone. So you can examine under the microscope. You can do an audiogram where you will find the degree of hearing loss and type of hearing loss. You can do culture and sensitivity of the ear discharge. You can also do mastoid X-rays and you can do CT scan or temporal bone CT. Coming to the treatment part. Now, in treatment, the main aim here is to control infection. Okay. And after you control infection, the second main aim is to eliminate the discharge. When you eliminate the discharge, you can hold the progression of the disease. So first of all, you can do an oral toilet. We say an ear toilet. You can give ear drops. You can give them systemic antibiotics. You can ask them to take certain precautions, right? And you can treat the other contributory causes. So ear drops, what is ear drops? You can give them antibiotic ear drops, okay, that contains neomycin or polymycin or gentamicin here. See, neomycin, polymycin, gentamicin, chloromycetin, any four of any antibiotic ear drops you can give. Okay, and these can be combined with steroids also that can act as an anti-inflammatory, that can give an anti-inflammatory effect. Now, this should be done 3 or 4 times in a day. So, acid pH will help to eliminate Pseudomonas infection, and care should be taken that the eardrops are likely to cause maceration of the ear canal also. It can cause maceration of skin, it can cause local allergy, it can cause fungal infections. If the patient is resistant to certain organisms, he might have resistance also. So you will have to ask the patient to follow up. It's not like you ask the patient to take this eardrops and send him back home. No, you will have to follow up with him after you give him antibiotics. And remember, there are certain ototoxic drugs that you should take care before using, like aminoglycosides. Now, systemic antibiotics are only useful in an acute exacerbation of a chronic infection where you see that the patient is having fever and it is involving his systemic metabolism. Otherwise, the role of systemic antibiotics in the treatment of chronic suppurative otitis media is very least known. Okay, coming to the part of precautions, the patients are instructed to keep water out of their ear. You should ask them not to, you cannot ask them not to take bath. Of course, they can take bath, but make sure they don't let the water enter the ear, or they avoid swimming, they avoid hair washing. They can use rubber inserts to block their ear before if they feel like, they have to take shower. And you should not ask them to blow their nose hard. When you blow your nose out, you create a negative pressure in your auscultation tube, right? So you should make sure that, you ask the patient not to blow hard. And because this will push the infection back into the nasopharynx if you have any, right? So this should be avoided. Now, treatment of contributory causes here, what does it mean is that the patient might have tonsillitis, he might have inflamed adenoids, or he might have nasal allergies. So that can also lead to chronic suppurative otitis media. So you should make sure that you treat the cause before you treat the symptom. Sometimes chronic suppurative otitis media is another cause. It can also show up like a symptom of a contributory cause. So always treat the cause before you treat the symptom. Make sure you treat the cause before you treat the symptom. You cannot apply it everywhere, but make sure you treat the cause before you treat the symptom. Now, surgical treatment, oral polyp or granulation, if there are any polyps or if there are any granulations, they should be removed before you start any local treatment with antibiotics. Because what will happen is that this will permit the eardrops to be entering into the ear effectively. Right? If there is an ear blockade, there's no point you're just superficially putting eardrops in the patient's ear. You just prescribed him and you're asking him to use, but his ear is blocked. It's not reaching to the point, right? So an oral polyp should never be avulsed. Remember, if you see a polyp in an ear, you should never reverse it, and it might uh, cause a rising effect on stapes. It can affect the facial nerve, and it can affect the horizontal canal, and it can lead to facial nerve paralysis. Okay, so if you see an oral polyp in a patient, never try to manipulate it. Reconstructive surgery is once the patient's ear is dry, once you control the infection, once there is no discharge, then you can do a meringoplasty. Okay, meringoplasty with or without ossicular reconstruction, if not required, you don't have to do ossicular reconstruction. So closure of the perforation is very important so that you avoid infection. So here you can see once the ear is dry, you can go for meringoplasty. Without ossicular reconstruction means that if ossicular chains are involved, you have to reconstruct them because this will lead to sensory neural hearing loss, right? Then this can be done by restoring hearing. Okay, so this is a reconstructive surgical procedure that you should do uh, for chronic suppurative otitis media. Now, chronic suppurative otitis media itself is of two types. Okay, So let's come to that point. Before that, we'll just understand the stages of retraction pocket. Okay, so retraction pocket has four stages. Four stages, yes. So the first stage is when tympanic membrane is retracted, right? But it does not contact with the incus. So if your retraction pocket is, if your tympanic membrane is retracted, but it will not touch the incus, that is first type, and it is very mild form of retraction. Now, type 2 is when tympanic membrane is retracted deep. So type 2 is when tympanic membrane is retracted deep and it will contact with the incus. So if it is contacting with the incus, it is known as type 2 retraction pocket. All right. Now coming to type 3 is also middle ear. It is also known as middle ear atelectasis. Yeah, you can see middle ear atelectasis. So middle ear atelectasis means a tympanic membrane comes to lie on the promontory and ossicles. Okay, so I'll go to this diagram. Let's take this diagram as a retraction pocket. Okay, so now in type 1, what will happen? This is type 1 retraction pocket, where the tympanic membrane is retracted, but it is not in contact with the incus. Whereas in type 2, what will happen is that it will get in contact with the incus. Okay. In type 3, what will happen? It will slowly lie on the promontory and the ossicles. Now, the middle ear space will be obliterated, but middle ear mucosa will be intact in type 3. Okay. And tympanic membrane will be lifted from promontory with a suction tip. Now, type 4, you will see an adhesive otitis media. It is called as adhesive otitis media, where tympanic membrane is very thin and it will wrap around the promontory on the ossicle. So here in type 3, what is that? It is lying on the promontory and the ossicle. But in type 4, what will happen is that it will start wrapping around the promontory and the ossicles. And then what will happen? The middle ear will not have enough space. And the mucosal lining will also be affected. It can either be absent or not seen in the tympanic membrane, gets adherent to the promontory. Okay. Now, retraction pockets are actually formed with which may collect keratin plugs. And this will form cholesteatoma. So, retraction pocket is a condition you will see in etico-antral type of chronic suppurative otitis media or in cases of cholesteatoma. Okay. So remember, stage 4 is an adhesive otitis media. I'll go back to that point. So type 4 is an adhesive otitis media. Tympanic membrane will become thin and it will wrap around the promontory and the ossicles. And there will be no space left in the middle ear. And what will happen? The mucosal lining, it will either be small, it will become absent, and the tympanic membrane will get adherent to the promontory. Now, retraction pockets are formed that might collect keratin plugs, and these might form cholesteatoma. Now, remember, cholesteatoma, pearly white flakes will be seen, and they are sucked from the retraction pockets outside. So, suction clearance and examination under the operative microscope is an important part for clinical examination and assessment of chronic suppurative otitis media. So, if you want to understand that this chronic suppurative otitis media is because of cholesteatoma, what you can see, if you see it in the patient's ear, if you see there is a retraction pocket and there is some pearly white flakes coming out of the retraction pocket, you can do suction clearance and you can examine it under the microscope. And under the microscope, what you will see keratinizing squamous epithelium. If you see that, then it means that it is cholesteatoma. It is an important part for a clinical examination of chronic suppurative otitis media, any chronic suppurative otitis media. Okay, so these are 3 stages of retraction pocket. Now, there are two procedures that we should know. Okay, so this is a treatment of chronic suppurative otitis media. You have to do oral ear toilet, and you will have to also use ear drops, like we have mentioned before. Yeah. So, treatment of eticoantral chronic suppurative otitis media. So, what actually happens here is that when there is a complication in chronic suppurative otitis media, the patient will have pain, the patient will have vertigo, the patient will have headache, they will have facial weakness because the facial canal is affected. So their facial nerve will also be affected. And the patient, if it is a child, he will avoid to eat and drink, right? They will have fever, nausea, vomiting. It will be a systemic involvement. Now, how do you treat the patient in a surgical way? You have learned I have explained you conservative management where you can use you do ear toilet, and then you slowly give them antibiotics along with corticosteroids. Make sure that the pathway is clear before you give them antibiotics, right? And you should follow up with the patient. Now, if these conservative management does not work, you will have to operate the patient, right? It is the mainstay of treatment. So primary aim of surgical treatment is to remove the disease itself and to keep the ear safe. And the second priority is reconstruction of hearing. So here, the main aim is to remove the disease. Okay? The main aim is to remove the disease. Now, there are two types of surgical procedures that are done to deal with cholesteatoma. Okay, so there is one called canal wall down procedure and canal wall up procedure. So what will happen is that in canal wall down procedure, they leave the mastoid cavity open. So here there's a mistake. It is a canal down procedure. Okay, so in canal down procedure, what will happen is that they will leave the mastoid cavity open in the external auditory canal so that there is fully externalized part of the middle ear. So you let the discharge come out of the middle ear, right? So you leave the mastoid cavity open to the external auditory canal, and you let the discharge come out. You give a part to the discharge, and this is usually performed for eticoantral type of disease. So you do an eticotomy, and you do a modified radical mastectomy, which is rarely, and you do a radical mastectomy. Okay, so here it is usually for eticoantral disease. You do an eticotomy. Okay, or you do a MRM, that is modified radical mastectomy and radical mastoidectomy. Three procedures. This one is very rarely done. It's either radical or it is eticotomy. Now, the other procedure is canal wall up procedure. Some mistake here. Canal wall down and canal wall up procedure. Here what happens is the disease is removed by combined approach through the meatus and the mastoid. But what will happen is that you will retain the posterior bony meatal wall. So there is a danger of leaving some cholesteatoma behind in this procedure. So incidence of residual or recurrent cholesteatoma in these cases are very high where you do a canal wall up procedure. So some surgeons, what they do is they advise a routine re-exploration in all the cases after 6 months in canal wall up procedure. So canal wall up procedures are advised only in selected cases. In combined approach or in intact canal wall mastectomy, disease is removed both permanently and through cortical mastectomy. And posterior tympanotomy approach is also done, in which a window is created between the mastoid and the middle ear through a facial recess to reach the sinus tympani. So in combined approach, what happens is that in combined approach, there is a canal wall mastectomy done where the disease is removed both permanently and through a cortical mastectomy. So you extract the disease first, and then you do a cortical mastectomy, and the posterior tympanotomy is also done, usually done, in which a window is created between the mastoid and the middle ear through a facial recess to reach the sinus tympani. Okay, so you can see here in combined approach or in intact canal wall mastoidectomy, disease is removed both permanently and then through cortical mastoidectomy and through posterior tympanotomy approach. Okay, here what is happening? The window is created between mastoid and the middle ear through facial recess to reach the sinus tympani. So here, how will you compare the canal wall up procedure by wall down procedure? So in canal wall up procedure, what we have studied just now, the meatal will be normal in appearance. The meatus will be normal in appearance, and it will not require routine cleaning in the patient. So if I have a space, okay, up, down, no routine cleaning. All right. In canal wall down procedure, it is completely the patient will be dependent on the doctor for cleaning. So it should be done, cleaning should be done once or twice in a year. Okay. Now, reoccurrence rate. Canal wall or procedure, even after you do a routine cleaning, the patient might have high rate of reoccurrence and he might have residual cholesteatoma. So reoccurrence is very high. Right? Whereas in canal wall down procedure, reoccurrence rate is low. Now, what else? Patient's limitations. There are no limitations. The patient is allowed to swim and he can take bath, and all these things can happen in canal wall up procedure. No limitations. Whereas in canal wall down procedure, the patient will have limitations, right? He will not be allowed to swim, and he will not be allowed, he will be asked to make sure that the water doesn't enter his ear. Now, auditory rehabilitation is the patient will have more, patient will be more comfortable wearing ear aid if it is a canal wall up procedure. But if it is a canal wall down procedure, the patient will have problem in fitting of a hearing aid because of the large meatus and mastoid cavity that can sometimes get infected. So the canal wall down procedure, the patient will have difficulty wearing hearing aid. But here he can wear an hearing aid. These are small comparisons of canal wall up procedure and canal wall down procedure. We have finished with stages of pocket retraction, right? Chronic suppurative otitis media. Okay. Coming to the next topic that we have is we have lateral sinus thrombophlebitis. So what is lateral sinus thrombophlebitis? Lateral sinus thrombophlebitis is an inflammation of inner wall of lateral venous sinus and formation of intrasinus thrombus. So here what will happen is the patient will have a thrombus formation. It can be either intrasinus or it can be a lateral venous sinus. Okay, so it is a complication. First of all, we'll understand what is hectic pectic fence type of fever with rigors. So here the patient will usually be accompanied by chills and rigors. So remember, we have a rigors here. So the patient will be having rigors, right? So it is known as hectic pectic fence type of rigors. Okay. It is usually accompanied by chills and rigors, and profuse sweating will be there, and follow a temperature. Clinical picture resembles malaria, but it will lack regularity. Of course, malaria is totally different from that, but patient will have some symptoms similar to malaria. Now, headache. It can be due to perisinus abscess and is usually mild. Okay. So later, the patient might develop severe intracranial pressure that is due to venous obstruction. So here the headache is usually due to increased intracranial pressure. So you have to make sure that you lower the patient's intracranial pressure when he's here in the hospital, right? So first of all is hectic pectic fence type of fever, and second is increased intracranial pressure. Now these patients will also have progressive anemia and emaciation. These patients will also show progressive anemia and emaciation. Now, other sign is Gressner's sign. Gressner's sign is due to thrombus of mastoid emissary vein. So, mastoid bone has emissary veins. This is anatomical part, right? So, they will have emissary veins. So, if there is thrombosis of emissary veins of mastoid bone, this will lead to edema over the posterior part of mastoid. Now, when there is edema in the posterior part of mastoid, the patient will show Gressner's sign. Okay. The other thing is papilledema. Papilledema is a painful condition. The patient will have pain in the eye, right? Like we all know. Then we have a Toby eye test. So this is to record the cerebrospinal fluid. So how do you record the cerebrospinal fluid? You actually record the pressure of cerebrospinal fluid by manometry. And you see the effect of manual compression of one or both jugular veins. So here you have to understand that if there is lateral sinus thrombophlebitis, this can lead to compression of both the jugular veins. Okay, so you have to make sure that you do a Toby-Airy test to see if cerebrospinal fluid pressure is normal and if it is compressing both the jugular veins. Right. Now, what happens is that usually what happens is compression of the vein on the thrombose side produces no effect, while the compression of vein on the healthy side produces rapid rise in intracranial, in cerebrospinal fluid pressure. And this will be equal to bilateral compression of jugular veins. I will repeat it again. If there is compression of vein on thrombose side, let's say the vein is compressed on the thrombose side, the patient's thrombose side is on the right side. So if the compression of vein is on thrombose side, it produces no effect. While compression of the vein on the healthy side, it will produce a rise in cerebrospinal fluid pressure, and this will be equal to bilateral compression of jugular veins. Okay. So Gressner's sign, papilledema, and Toby-Airy syndrome. Now, papilledema, the patient will have pain. So its presence will depend upon the obstruction to the venous return. So the fundus may show small blurring of the disc margins. The patient might have retinal hemorrhages also. Okay. Now, other thing is Crowley-Beck test. So here again, it is a pressure on jugular vein of the healthy side that will produce engorgement of retinal veins. So if there is pressure on the jugular vein on the healthy side, there will be pressure on the retinal veins, right? And engorgement of veins that will subside when you release the pressure. So in Crowley-Beck test, what you do is you put a pressure on jugular vein, and if it is on the healthy side, it will lead to engorgement of retinal veins. So no, remember, you should by heart these test names: Toby-Airy test, Crowley-Beck test, right? And this one also, hectic pectic fence type of fever with rigors. Okay, it's just like a podium hectic pectic fence type of fever. Toby-Airy test, Crowley-Beck's test, and then there is tenderness along the jugular vein. Of course, this is seen when there is thrombophlebitis that has extended along the jugular vein. And there will be associated with enlargement and inflammation of jugular chain of lymph nodes. And the patient will have torticollis. What is torticollis? The patient will not be, it will be a painful movement of the neck. The patient will have neck pain and he will be twisted on the other side, right? So this is when thrombophlebitis has extended into the jugular vein. So this is what you should write in the exam if they ask you lateral sinus thrombophlebitis. This is more than enough. If you do not remember all these points, then you can learn the investigations. I'll mention it here so that you don't lose a point. If you lose any point in the symptom, you can, just manage it by writing some points in investigation. So what investigations you do? You do a blood smear test to see if there is malaria or not, because the symptoms are sometimes similar to malaria, right? And you do a CSF examination. You do an X-ray of mastoid bone, right? And you do a CT scan if required. So now remember that it's more than enough if you write all these symptoms. If you don't remember anything, and if you think that you missed any point, you can just add on a heading called investigation, and just write, you have to investigate blood smear, you have to do CSF examination, you have to do an X-ray of mastoid, or you can do a contrast and have CT scan to see if a patient is having thrombosis or not. Coming to autogenic brain abscess, this is actually a very short answer. It is a 2-marker question, but I'll just try to give you a brief idea. So, pathology, first of all, what is autogenic brain abscess? So, 50% of brain abscess in adults and 25% are in children. Okay, so in adults, abscess usually follows chronic suppurative otitis media. So autogenic brain abscess is actually a complication of chronic suppurative otitis media with cholesteatoma. So if someone is having cholesteatoma and then he gets into a complication of chronic suppurative otitis media, and then he gets into complication known as autogenic brain abscess. This is in adults. Now cerebral abscess is seen twice as frequently as cerebellar abscess. It is usually common. So I'll tell you, I'll just for your clinical information, patients with brain abscess, they will vomit as soon as they get up in the morning. This is the first sign. They will have fever and they will throw up as soon as they get up in the morning. They will complain of headache and they will vomit. This is the first sign. Every time any patient who comes who's physically fit, but then he says, I have headache, and as soon as I get up in the morning, I vomit, and he has a fever, then you can suspect 70% of the time that it is cerebral abscess. Okay. So route of infection, it is direct extension from the middle ear infection through tegment tympanum by retrograde thrombophlebitis. Okay. So cerebral abscess can also develop as a direct extension. Now, coming to pathology, this is more important. This is pathology. Stages of invasion. So first, it is initial encephalitis. It's known as initial encephalitis. So what happens here is that usually the patient will go unnoticed. He might have symptoms, usually slight symptoms that he might relate it to a normal headache. So patient might have headache, but he might relate it to, just a normal random tension headache or migraine or cluster headache or whatever. Now, the second stage will be latent abscess stage. So in latent abscess stage, there are no symptoms again, but what will happen is that there will be localization of the pus by formation of capsule. Okay, this stage will be lasting for several weeks. So there will be a stage where the pus will localize, right, and there will be formation of capsule. All right. Now, there is one more stage called stage of enlargement. This is also known as manifest abscess. So what happens here is that abscess has set in, the capsule has been formed, and the pus has been localized. Now, this abscess will start to grow. And this zone of edema will appear as a round abscess. And now, from here, the patient will start showing symptoms. What will be the symptoms? The patient will have raised intracranial pressure, headache, Okay, he will have dizziness, nausea, weakness, vomiting, headache, all these things. So from third stage, from stage of enlargement, when the manifestation of abscess happens, the patient will start throwing up symptoms. Now, for stage of termination, the abscess might rupture. Now, this is a very dangerous stage. An expanding abscess in a white matter of brain will rupture that will enter into the ventricles and subarachnoid space. Now, this is very fatal and the patient will have fatal meningitis. Okay, so remember it like this, the first two stages are non-symptomatic. Last two stages are symptomatic. Now remember, I told you the patient with abscess, cerebral abscess, he will tell you that I had recurrent ear infection or upper respiratory tract infection. He will tell you this. I had infections, I had history of infections, and then I have headache now and I vomit every time I get up in the morning. Kidding, it's a red flag. It's cerebral brain abscess. Okay. Clinical features I have mentioned, there will be increased intracranial pressure, there will be dizziness, there will be now if it depends upon the side of the brain that is involved with the abscess. Okay, it is localizing features. So remember, headache, nausea, vomiting, papilledema, increased intracranial pressure, patient will have fever, nausea, vomiting. Okay, now there will be hemianopia, there will be contralateral motor paralysis if it is towards the internal capsule, right? The patient might have epileptic fits also. It all depends upon the site of the abscess. Just forget that, generalize it in the exam. When they ask you autogenic brain abscess, give a definition of autogenic brain abscess, that it is a complication that is seen in conditions in adults where they have chronic suppurative otitis media with cholesteatoma, while in children it is usually because of acute otitis media. Okay, and then you should go down to pathology and write 4 stages of invasion: state of invasion, state of localization, state of enlargement, and then state of termination. Now remember, state of termination is a fatal condition. All right. I think this is a CT scan. You can see here, you can appreciate. This is a capsule formation. You can see a capsule and then you can see an abscess. This is a capsule. All right. Okay. Before we end, I just give you small information, investigations, what you should do, just so that you don't get curious. So investigations can be skull x-rays. It can be CT scan, like just like how I showed you here. It is a CT scan. It is the most important mean of investigation if you suspect a brain abscess. Skull x-rays can be useful. It can be useful to see if the patient is having any midline shift or if he is having his pineal gland calcified, right? Skull x-rays are useful, but the best test that you can do is CT scan. X-ray of mastoids and X-ray of CT scans are all those later on. But remember, the first thing that you can do is skull X-ray and then CT scan of head. All right. So this is it. Thanks for watching.
Hello,
Okay.
ma'am.
Hello. Now here the option for polls and quizzes have gone. I don't know where it went. I was not able to post or launch polls and quizzes.
Yes. 1 minute, ma'am. Uh, okay, ma'am. Here we have the two polls, ma'am. Launching one, 5 questions is there, ma'am.
I cannot
So
see it on my screen. I don't know why.
1 minute, ma'am. So
Anyways, should I launch it now? Where is Shiva? Shiva, should I
yeah,
launch
you
it now?
can.
Yeah, ma'am,
1 minute,
ma'am.
ma'am. Yes, ma'am, you can.
I don't know why I couldn't see it before.
It's okay, ma'am.
Should I launch it now?
Yeah, ma'am.
సాహిత్య గారు ఇంకొక లైక్ కోఆర్డినేషన్ పర్సన్ ఉన్నారు the machine link next.
Okay, why was I not able to see it before? I think
Answer was there already, ma'am. I think
huh?
answer was there only. Like it's showing which of the following is not a characteristic of chronic otitis media. The answer should be acute pain and high fever.
Hi Raju, Raj garu. Here we have our team member Santi garu. She is taking our first round of interview. Can you please intro about yourself?
It's okay, ma'am. So we are done, ma'am. I think for next class, we'll
For
try to.
next class, I think we should, I think we should launch the polls and quizzes in the beginning,
Hello.
and I think you guys should do it by yourself
Can you please
because
intro
I'm not
about
able to
yourself?
see it here.
Yeah, ma'am. We'll make it.
Can
Ma'am.
you please intro about yourself?
సౌమ్య నీ వాయిస్ ఎక్కడ వస్తుంది? మ్యూట్ చేసుకో.
Sorry.
Okay, ma'am. So the session was so good,
Okay.
ma'am. The live also very
Thank you, sir.
good, ma'am. I'll share you the link, ma'am.
Yes, okay.
Okay, ma'am.
Done.
Thank you so much, ma'am.
Okay. Thank you.